Bismillahirrahmanirrahim. In this lecture, we will discuss the tumors of the oropharynx. The tumors of the oropharynx may be benign and they may be malignant ones. The benign tumors are papilloma, pleomorphic adenoma, hemangioma, lipoma, fibroma, neuroma. Whereas the malignant tumors are squamous cell carcinoma, lymphoepithelioma, adenocarcinoma, and lymphomas, which may be Hodgkin's lymphoma or non-Hodgkin's lymphoma. Carcinoma of the oropharynx. In this figure, you can see the pharynx can be divided into three parts. Nasopharynx, above the soft palate, and then the region between the soft palate and the hide bone is the oropharynx, and below that is the laryngopharynx or the hypopharynx. Subsites of the oropharynx. These are the sites where the malignant tumors may make their appearance. These subsites are base of the tongue, tonsil and tonsillar fossa, partial palatine arch, that is soft palate and anterior pillar, posterior wall of the pharynx, oropharynx, and lateral wall of the oropharynx. Epidemiology of carcinoma of the oropharynx. Oropharyngeal cancer is uncommon. About 1,340 people are diagnosed each year in the United Kingdom. Any age may be affected, but this cancer is more likely to affect people over 50 years of age. It is more common in men than in the female. There are different types of oropharyngeal cancer, but the most common is the squamous cell carcinoma. Round about more than 90% of the cancer is the squamous cell carcinoma. Oral and oropharyngeal cancer is one of the most common types of cancer in Asia due to its association with smoking, tobacco, bidi, betel quid, and alcohol consumption. Regionally, incidence varies with highest rates in South Asia, particularly India, Bangladesh, Sri Lanka, Pakistan, and Afghanistan. Types of malignant tumors of the oropharynx. Different types of malignant tumors which occur in the oropharynx are: number one is the squamous cell carcinoma. It is more than 90% of the cases. Second one is the lymphoepithelioma, adenocarcinoma, lymphomas, which may be Hodgkin's lymphoma or non-Hodgkin's lymphoma. According to WHO classification, the oropharyngeal cancer or the cancer of the tonsil may be human papillomavirus positive oropharyngeal cancer, or it may be human papillomavirus negative oropharyngeal cancer. Human papillomavirus positive oropharyngeal cancer is characterized by HPV positive patients tend to be younger. They have a higher socio-economic status and they are less likely to smoke. In addition, they tend to have smaller tumors but are more likely to have involvement of the cervical lymph nodes. A better response to treatment and a better outcome independent of the treatment methods used. Most recurrence occurs locally and within the first year after treatment. However, the use of tobacco decreases the chances of survival. HPV positive oropharyngeal cancer may present in one of the four ways: as an asymptomatic abnormality in the mouth found by the patient or a health professional such as a dentist, with local symptoms such as pain or infection at the site of the tumor, with difficulties of speech, difficulty in swallowing, and or difficulty in breathing. Or sometimes the patient may have presentation as a swelling in the neck if the cancer has spread to local lymph nodes. Detection of a tumor suppressor protein known as E16 is commonly used to diagnose HPV-associated oropharyngeal cancer. Most head and neck cancers are declining because reduced smoking rates have declined, but HPV-positive oropharyngeal cancer is increasing. This increase is seen particularly in young men in developed countries, and HPV-positive oropharyngeal cancer now accounts for the majority of all oropharyngeal cases. Efforts are being made to reduce the incidence of HPV-positive oropharyngeal cancer by introducing vaccination that improves HPV type 16 and 18, which is found in 95% of these cancers, prior to exposure to the virus. Early data suggests a reduction in infection rates. HPV positive oropharyngeal cancer is usually diagnosed at a more advanced stage than HPV negative oropharyngeal cancer, with 75 to 90% having involvement of the regional lymph nodes. Moreover, non-keratinizing squamous cell carcinoma is strongly associated with HPV negative oropharyngeal cancer. Oropharyngeal cancer HPV positive oropharyngeal cancer is associated with expression of P16 and are histopathologically characterized by their verrucous or papillary structure. HPV positive oropharyngeal cancer is characterized by the presence of HPV P16. There is not a standard HPV testing method in head and neck cancers. Both in situ hybridization and polymerase chain reaction are commonly used. Both methods have comparable performance for HPV detection. Prognosis. People with HPV positive oropharyngeal cancer tend to have higher survival rates. The prognosis for people with oropharyngeal cancer depends on the age and health of the person and the stage of the disease. It is important for the people with oropharyngeal cancer to have follow-up exams for the rest of their lives, as cancer can occur in nearby areas. In addition, it is important to eliminate risk factors such as smoking and drinking alcohol, which increase the risk for second cancers. Etiology of oropharyngeal cancer. Exact etiology is not known yet, but there are certain risk factors which are responsible for oropharyngeal cancer. These are, number one, major risk factors. The major risk factors include tobacco. This is the greatest single cause of oral and oropharyngeal cancer. It is a known multi-organ carcinogen which has a synergistic interaction with alcohol to cause cancers of the mouth and oropharynx by directly damaging the cellular DNA. Tobacco is estimated to increase the risk of oral and oropharyngeal cancer by 3.4 to 6.8 and is responsible for approximately 40% of all oral and oropharyngeal cancers. Use of both tobacco and alcohol increases the risk by 10 to 15-fold in some studies. Second important risk factor is the heavy alcohol use. Third is the Epstein-Barr virus infection, which is rarely involved. The fourth and most important risk factor is the human papilloma virus. This is a very important factor. Infection with human papilloma virus, that is HPV, particularly type 16, is a known risk factor and independent causative factor for oral and oropharyngeal cancer. The following are the victims of HPV infection: people over 50 years of age, blacks over whites 2:1, males over females 3:1, and 75% of the people who have used tobacco products they are heavy users of alcohol. HPV 16 is the primary risk factor in this new population of oral cancer victims. HPV 16 is the same virus responsible for the vast majority of all cervical cancers and is the most common sexually transmitted infection in the United States of America. Oral cancer in this group tends to favor the tonsil and tonsillar pillars, base of the tongue, and the oropharynx. Recent data suggests that individuals that come to the disease from this particular cause have a significant survival advantage, as the disease responds better to radiation treatments than tobacco-caused disease. Minor risk factors. These are a diet low in fruits and vegetables, chewing betel quid, palm, a stimulant commonly used in parts of Asia, iron deficiency anemia, Palmer-Vinson syndrome, poor nutrition, asbestos exposure, certain genetic changes including P53 mutation and P16 mutation. Third is there are certain precancerous lesions which may predispose the patient to develop oropharyngeal cancers. These are high-risk lesions, for example, erythroplakia, speckled erythroplakia, chronic hyperplastic candidiasis. There are certain medium-risk lesions, for example, oral submucosal fibrosis, syphilitic glossitis, and there are certain low-risk lesions which may develop into oropharyngeal cancer. For example, oral lichen planus, discoid lupus erythematosus, and discoid keratosis congenita. Gross appearance of oropharyngeal cancer. It may appear exophytic or fungating growth just like a cauliflower, or it may appear as an ulcerative growth and sometimes infiltrative under the mucosa. These are the three important types of growths which may make their appearance in the oropharynx on gross appearance. Histology. The commonest variety is the squamous cell carcinoma, which is around about more than 90%. It may be well differentiated, moderately differentiated, or poorly differentiated squamous cell carcinoma. Second is the lymphoepithelioma, adenocarcinoma, or lymphomas. Spread of the oropharyngeal cancer. It may spread by one of the three ways. Number one, local spread to adjacent tissues through the tissue continuity. Second is the lymphatic spread to the lymphatics to the regional draining lymph nodes. And third one is the blood-borne spread through the capillaries and veins to the distant organs, for example, lungs, liver, bones, and brain. Pattern of spread to the lymph nodes. Cancers arising in the tonsillar fossa spread to the cervical lymph nodes, primarily the subdigestive, that is upper jugular lymph nodes, level 2, with secondary involvement of the mid, level 3, and low, level 4 jugular lymph nodes, and sometimes the posterior cervical lymph nodes, level 5. Tonsillar cancers rarely spread to the contralateral side unless involving the midline. Clinical features. Clinical features depend upon site of the malignant tumor, stage of the tumor. Different possible clinical features may be a sore throat that persists for a long time despite the treatment. Most common presentation in HPV negative oropharyngeal cancer. The patient may have dysphagia, odynophagia, an unhealed ulcer in the oropharynx, unexplained weight loss, change in the quality of voice in the form of hot potato voice. The patient may have ear pain, which is actually the referred otalgia, bleeding from the throat or mouth, trismus. If the patient has pterygoid muscles are affected, the patient may have bad smell from the throat, the patient may have a lump in the throat, and the patient may have a lump in the neck due to lymph node metastasis. This is the most common and initial presentation in HPV positive oropharyngeal cancer. Investigations. Apart from routine investigations, the specific investigations which are important ones are computerized tomography, that is the CT scan of the head and neck from base of the skull to the root of the neck. It may show site of the tumor, extent of the tumor, and lymph node metastasis in the neck. Second, magnetic resonance imaging. Similarly, PET scan, positron emission tomography, incisional or excisional biopsy for histopathology, which will confirm the diagnosis. TNM classification of oropharyngeal cancer. T stands for primary tumor size in greatest dimension. N stands for regional lymph node involvement, and M stands for distant metastasis in the body, that is the lungs, liver, bones, and brain. Primary tumor. T1. The tumor size is 2 centimeter or less in greatest dimension. T2. Tumor size more than 2 centimeter but not more than 4 centimeter in greatest dimension. T3. Tumor size more than 4 centimeter in greatest dimension. T4A. Tumor which has invaded larynx, deep or extrinsic muscles of the tongue, medial pterygoid, hard palate, or the mandible. T4B. The oropharyngeal tumor which has invaded lateral pterygoid muscle, pterygoid plates, lateral nasopharynx, or base of the skull, or has encased the carotid artery. Regional lymph node metastasis. N. NX means regional lymph nodes cannot be assessed. N0, no regional lymph node metastasis. N1, metastasis in a single ipsilateral lymph node 3 centimeter or less in greatest dimension. Then N2, metastasis in a single ipsilateral lymph node more than 3 centimeter but not more than 6 centimeter in greatest dimension. Or metastasis in multiple ipsilateral lymph nodes, none more than 6 centimeter. Or metastasis in bilateral or contralateral lymph node, none more than 6 centimeter in greatest dimension. Now, these N2 metastasis can be further subdivided into N2A. N2A means metastasis in a single ipsilateral lymph node more than 3 centimeter but less than 6 centimeter in greatest dimension. N2B, metastasis in multiple ipsilateral lymph nodes, none more than 6 centimeter. N2C, metastasis in bilateral or contralateral lymph nodes, none more than 6 centimeter. N3, metastasis in a lymph node more than 6 centimeter in greatest dimension. Distant metastasis. MX means distant metastasis cannot be assessed. M0, no distant metastasis. M1, distant metastasis. Staging of the oropharyngeal cancer. Stage 0 means carcinoma in situ. N0, M0. Stage 1, T1, N0, M0. Stage 2, T2, N0, M0. Stage 3, T3, N0, M0, or T1, N1, M0, or T2, N1, M0, or T3, N1, M0. Stage 4A, T4A, N0, M0, T4A, N1, M0, T1, N2, M0, T2, N0, T2, N2, M0, T3, N2, M0, T4A, N2, M0. All these categories, they belong to stage 4A. Stage 4B, T4B, any N, M0, any T, N3, M0, and stage 4C, any T, NEN-MY. Diagnosis. Diagnosis depends upon history regarding clinical features and the risk factors. Second, physical examination of the patient, which may include inspection of the site of the tumor, digital palpation of the tumor to know its size, extent, margins, and fixity to other surrounding structures. Third, palpation of the tumor under general anesthesia if required. And fourth, palpation of the neck lymph nodes. And C is investigations, which I've already mentioned. All these three, history, examination, and investigation, they will diagnose the condition. Treatment. It depends upon different factors: age of the patient, fitness of the patient, site of the tumor, extent of the tumor, that is, stage of the tumor, lymph node metastasis present or not, type of histology of the tumor, facilities available at the center, experience of the surgeon, functional loss due to surgery, and patient's preference. Different treatment options. Number one is surgery alone. For example, if the patient presents with advanced carcinoma of the tonsil and tonsillar fossa, then wide surgical excision with hemimandibulectomy and neck dissection. This is commonly known as a procedure called commando operation. Second, radiotherapy alone. Third, combination of surgery and radiotherapy. Fourth, chemotherapy alone or as an adjuvant to surgery or radiotherapy. And the final one is palliative therapy in very much advanced lesions. Palliation may be done by radiotherapy or chemotherapy. Such patients usually end up with tracheostomy and feeding gastrostomy. Management of lymph node metastasis. Spread of the cancer from oral cavity or oropharyngeal cancer to the lymph nodes of the neck has a significant effect on survival. About 60 to 70% of the people with early stage oral cancer will have no lymph node involvement of the neck clinically. About 20 to 30% of those people will have clinically undetectable spread of cancer to the lymph nodes of the neck. This condition is called occult disease. The management of the neck is crucial because spread to it reduces the chance of survival by 50%. If there is evidence of lymph node involvement of the neck during the diagnostic phase, then a modified radical neck dissection is generally performed. If the neck lymph nodes have no evidence of involvement clinically, but the oral cavity lesion is high risk for spread, for example, if the tumor is stage T2 or above lesions, then a neck dissection of the lymph nodes above the level of the omohyoid muscle may be complete. When the disease is found in the nodes after removal but not seen clinically, the recurrence rate is 10 to 24%. If post-operative radiation is added, the failure rate is 0 to 15%. When lymph nodes are clinically found during the diagnosis phase and radiation is added post-operatively, then the disease control is more than 80%. Chemotherapy and radiotherapy. Chemotherapy and radiotherapy are most often used as an adjuvant to surgery to control oral and oropharyngeal cancer that is greater than stage 1 or has spread to either regional lymph nodes or other parts of the body. Radiotherapy alone can be used instead of surgery for very small lesions with curative intention, but is generally used as an adjunct when lesions are large, cannot be completely removed, or have spread to the lymph nodes of the neck. Chemotherapy is useful in oral cancer when used in combination with other treatment modalities such as radiation therapy, but it is not used alone as a monotherapy. When a cure is unlikely, it can also be used to extend life and can be considered palliative but not as a curative modality. Role of monoclonal antibody therapy in management. Role of monoclonal antibody therapy with agents such as cetuximab have been shown to be effective in the treatment of squamous cell carcinoma of head and neck cancers and are likely to have an increasing role in the future management of this condition when used in conjunction with other established treatment modalities. Although it is not a replacement for chemotherapy in head and neck cancers, likewise, molecularly targeted therapies and immunotherapies may be effective for the treatment of oral and oropharyngeal cancers. Prevention. One is avoiding exposure. Prevention of HPV positive oropharyngeal cancer involves avoiding or reducing the exposure to risk factors where possible. Second method by which you can prevent this oropharyngeal cancer is the vaccination. About 90% of the HPV positive oropharyngeal cancer carry HPV 16 and another 5% type 18. These two types are both targets of available vaccines. HPV vaccines given prior to exposure can prevent persistent genital infection and the consequent precancerous stage. Therefore, they have a theoretical potential to prevent oral HPV infection. Now, I would like to mention the differences between HPV positive and HPV negative oropharyngeal carcinoma. HPV positive oropharyngeal carcinoma is associated with human papillomavirus type P16, so it could be the cause. Whereas HPV negative oropharyngeal cancer, this papilloma, human papillomavirus, is not associated in HPV negative oropharyngeal cancer. HPV positive oropharyngeal cancer is sexually acquired as there is extensive sexual history in the patients, both oral sex, especially open mouth kissing, and vaginal sex and change of sexual partners. But in HPV negative oropharyngeal cancer, no such history is seen. Incidence is increasing in USA and in Europe in case of HPV positive cancer, whereas the incidence is decreasing in HPV negative oropharyngeal cancer. In oropharyngeal positive cancer is relatively seen in younger patients who have higher socioeconomic status. In case of HPV negative oropharyngeal cancer, majority of the patients are older, more than 50 years of age, and they have low socioeconomic status. HPV positive, they are non-smokers, whereas history of tobacco smoking and alcohol intake is seen in case of HPV negative oropharyngeal cancer. HPV positive cancer patients are white males, whereas on the other hand, in HPV negative oropharyngeal cancer, the black males are more prominently seen. In HPV positive cancer, smaller tumor is seen at the primary site. In HPV negative oropharyngeal cancer, larger lesion is seen at the primary site. HPV positive cancer is diagnosed at a more advanced stage, whereas HPV negative cancer may be diagnosed at an early stage. In case of HPV positive cancer, HPV typically infects the crypts of lingual and palatine tonsils, so it involves the lymphatics at an early stage. In this way, early renal lymph node, that is the level 2 metastasis, and so early neck mass is seen in HPV positive oropharyngeal cancer. These tumors, on the other hand, HPV negative oropharyngeal cancer, these tumors arise from surface epithelium and present with clinical features of primary tumor site. In case of HPV positive cancers, Most common and initial symptom is the neck mass. Sore throat, dysphagia, rhinophagia, bleeding, and weight loss are less likely. In case of HPV negative oropharyngeal cancer, the most common and initial symptoms are sore throat, dysphagia, rhinophagia, bleeding, and weight loss. In HPV positive cancers, better survival rate is seen and so good prognosis. On the other hand, in HPV negative oropharyngeal cancer, the prognosis is poor. This is the figure, a photograph showing you the tumor or malignancy of the right palatine tonsil. This is the growth involving the right tonsil as well. This is a smooth mass or growth involving the right tonsil. This is a case of lymphoma. This is the tumor involving the posterior pharyngeal wall in the oropharyngeal region with an overlying ulcer. This is the growth of soft palate. This is the contrast enhanced CT scan of the oropharyngeal region showing you the growth of the right tonsil. This is the CT scan axial view on one side in A and the sagittal or parasagittal view in the B photograph showing you the base of the tongue tumor. This photograph is the CT scan of the head and neck showing you the growth of the soft palate. This figure is showing you the growth of the posterior oropharyngeal wall. Thank you so much.